The scapula is an interesting area to palpate. There are lots of things that are going on. There are lots of muscles that have their origin or insertion into the scapular region. The scapula is very, very important for control of the shoulder. And so this is a good area to learn how to palpate in. Plus we also have the rotator cuff muscles that are mainly in this region. So to find the medial edge of the scapula, so since this is a bony edge, remember we're going to try to come in perpendicular, and we're going to do hard and fast palpation. I'm trying to get my hand where you can see it. Now if you have a hard time finding the medial border of the scapula, you can ask your patient to bring their hand to their back, and you will find that this will then protrude and cause the scapula to come up off of the back. And now I can very easily palpate that medial border up and down the spine here. Okay, and I want to come in hard and fast in that perpendicular area. Another area I want to find is the spine of the scapula. So as I move superiorly, I'm going to come across a bony ridge. And that is the spine of the scapula underneath my fingers here, and I can follow that bony ridge as it comes out here to where it forms the acromion of the shoulder. And remember how I mentioned that different levels or areas on these different parts of the bones also can help you decide where you're at on the rest of the body. So the spine of the scapula, where that is located at, can typically be found at T3. The inferior angle of the scapula typically is going to be located at T7. So this is another way that you can use to find landmarks within the spine. So a bony prominence that we can palpate is the lateral aspect of the acromion. And with bony prominences, we're going to be coming in perpendicular. We want to come in a little bit hard and fast with our palpation. So we need to find the spine of the scapula in the posterior aspect. And as that comes around, remember that is what is forming the acromion here. And from the anterior aspect, it's the clavicle. So if I find the clavicle, I'm going to come down. There's my acromioclavicular joint. I have that little divot in there. And as I come around, there is my acromion. Now my acromion, in this case, on this patient, is about that wide. That's one of the things I'm always kind of reminded of, is really how wide that acromion is here. If I want to palpate along the other edge, I'm going to come in perpendicular to that in that hard and fast motion. And it's important, again, to find these types of bony landmarks, because for one thing, the infraspinatus is going to insert in that posterior aspect, and the supraspinatus is going to come superior to the spine of the scapula and is actually going to come under the acromion and inserts into the humerus in approximately this area. So if someone is having some supraspinatus tendinitis, they typically will have an issue here. So we need to be able to find that lateral edge and that bony edge of the acromion. One of the other bony edges we're going to be palpating is the mastoid process. Remember, we're going to have our fingers that are perpendicular to this area. So to find this, we can have the patient in a supine position in the head and neck and slight flexion, which the pillow allows her to be in that slight flexion. And we're going to find the earlobes, and we're just going to go directly posterior to the earlobes. And remember, we're going to have that perpendicular type motion, and we're going to find the mastoid process. Right? And this is important because it serves as an initial landmark in order for us to find C1. Because actually just posterior to that, if we push straight in, this is going to be the transverse process for C1 right here. It's this far out lateral, Typically it's a little tender. My patient was making little faces a second ago. So it's typically a little tender to palpation, but you're going to find that that's right behind the mastoid here. The mastoid is also another important location or area to find because it is also the origin of the sternocleidomastoid muscle. A nice bony prominence that is easy to find and is also clinically relevant is the tibial tuberosity. So if I find the inferior pole of the patella and I'm going to follow the patellar tendon down and where it inserts, you have a bony prominence down here. I'm going to use my circular technique, but I can palpate all around to that edges. I'm also going to have that flat technique. So this is where the patellar tendon comes down, inserts into the tibial tuberosity. And there is a condition that's called Ashgard-Schlatter. And what happens is, especially in teenage years when people are growing, and if particularly more with athletes, the muscles are overpowering the bone, because remember the bone is actually changing, so you are losing bone and creating bone, and that tendon is pulling so hard on the bone it actually pulls part of the bone away. It's a little bit of an avulsion, and so then the body lays down additional bone, and so you might see some people that have some larger tibial tuberosities that maybe had some knee pain when they were teenagers. One of the important bony prominences to find is the greater trochanter, which lies off the lateral aspect of the upper femur. And this is important because it's where the gluteal muscles insert, and there's also a bursa that lies behind it. And so we're also going to be palpating for the bursa in this particular case as well. But to find the greater trochanter, you're going to find the iliac crest and come in across on that iliac crest, and then you're just going to work inferiorly. So here's the ilia, there's the ilia, until you run into this bony prominence. And that's going to be the greater trochanter. And one of the ways you can tell if you're on it or not is you can internally and externally rotate the patient's legs. So what I'm doing is I'm rotating the toes out and I'm rotating the toes in. And what I'm going to palpate for is underneath my fingers, I'm going to feel that greater trochanter roll underneath my fingers as I'm internally and externally rotating that hip. And so my greater trochanter is right here. And for those bony prominences, remember we're doing a circular pattern with our finger pads and not a lot of pressure. The bursa in this particular case lies just posterior to the greater trochanter, so I typically prefer the patient to be in sideline when I palpate for the greater trochanteric bursa. And we're going to come in again posteriorly to the greater trochanter and push down both inferiorly and anteriorly in order to palpate for the bursa. And you're not going to feel a bursa that's normal. Remember, what you're looking for is a positive response in terms of that there's pain with palpation. There are several structures that we can palpate in the area of the elbow. A bony prominence that we can palpate is the medial condyle of the humerus. So that is located in this area, and you can, again, this is your broad palpation with 2 fingers or 3 fingers, depending on how large of an area that you're looking for. We're going to use a circular motion so that we can palpate all aspects of the condyle here. And this is important for a couple reasons. One is because this is where the common origin for the flexor tendons for the forearm are located, and is a site if someone has golfer's elbow or medial epicondylgia, then this is when we palpate in this area, they're going to be very tender. The other reason why this is important is because of the ulnar collateral ligament in the elbow. And the ulnar collateral ligament actually has two different heads to it that come together and form a common ligament down to the ulna. And the anterior portion, which is directed obliquely forward, and it is attached to the front part of the medial epicondyle. So again, up in this region, up in through here, the posterior portion, which is also a triangular form. So both of these ligaments look like triangular, to the lower and the back part of the medial epicondyle, so back in through this region, and again below to the medial margin of the olecranon, and then the anterior portion into the ulna in through here. And this is an important ligament to be able to palpate, and of course we're going to have some special tests for it. This is the ligament that gets injured in baseball players with Tommy John, if you've heard of Tommy John surgery or Tommy John injuries. And typically that's what's happening, is you're tearing that ulnar collateral and medial elbow collateral ligament. So this is an important ligament to be able to find and to palpate.